Hello, my name is Leon Menezes. I'm a consultant radiologist and a nuclear medicine physician at the Institute of Nuclear Medicine at UCL and here in the Barts Heart Centre. This series of talks from the British Nuclear Cardiology Society we've recorded is to give you the basic grounding in nuclear cardiology, the applications, the technology and the evidence. We hope you find them interesting and useful. Infective endocarditis and the application of PET. I'm going to start with a case. An 80-year-old man with a previous history of having tissue aortic valve replacement and mitral valve replacement for previous endocarditis. He'd recently been admitted with hospital, a long stay with an infective exacerbation of COPD, complicated by acute kidney injury, hospital-acquired pneumonia and delirium. However, he was discharged to a rehab centre but was readmitted with fever and dysuria. Working diagnosis was urosepsis, but during this second admission he developed splinter hemorrhages and Janeway lesions. Transthoracic echo was negative and it proved impossible to perform a TOE twice. The blood cultures were variously positive and negative with differing bacteria. Microbiology were not 100% convinced this may be endocarditis. A diagnostic test was performed. This is the FDG PET of the patient, and I'm just going to let it run through. First of all, we realise that FDG PET is whole body imaging. Don't worry, we're coming to the heart now. We'll let that repeat, just so you can get an concept of what's going on with this patient. So these are the highlight slides, if you will, showing focal increased uptake on the aortic prosthetic valve and muscle uptake in his left thigh and in his left arm, as well as osteomyelitis with destruction of a transverse process of the lumbar vertebra. So in one test we confirm the diagnosis of endocarditis and can effectively stage the disease, demonstrating where infection has seeded. So there's a rising incidence of infective endocarditis. This is 5-year-old data now in the Lancet, showing that whilst mortality hasn't particularly changed, the incidence is going up. And there may be an inflection point here when NICE guidance was changed with regard to prophylactic antibiotics. But there are many reasons as to why there's a rise in global incidence of infective endocarditis. There are more patients at risk, for starters. There are more patients with devices implanted within them, more patients with valves, and there is a rising incidence of nosocomial infection, and there is less use of prophylactic antibiotics. Moreover, the infections are more aggressive. There's many more staph infections than there used to be with strep infections. The average age of the patients is rising, and therefore there's more comorbidity and more frailty. And the one-year mortality at over 30% is really unchanged over the last 20 years. How do you diagnose infective endocarditis? Well, we apply the modified Duke criteria, but we're aware that they're less sensitive in prosthetic valve endocarditis, device infection, and in right-sided endocarditis. So recent European guidance suggests that you, first of all, entertain the diagnosis of infective endocarditis, apply the modified Duke criteria, and then you could have either got definitive endocarditis or you reject the diagnosis of endocarditis, but a large proportion of patients fall into the possible category. And then here there's a role for imaging beyond the echo to determine whether these patients do have endocarditis or not. And the role for imaging differs as to whether you've got a native valve or a prosthetic valve, like the patient in the case. So a prosthetic valve patient, repeat the echo, transthoracic or transesophageal if you can, repeat the microbiology, and then it recommends FDG PET or white cell labeled SPECT scanning, cardiac CT, and or imaging for embolic events. Whereas if you have a native valve and you still have possible endocarditis, again, repeat the echo, transthoracic or esophageal, repeat the microbiology, image for embolic events, and request a cardiac CT. Transesophageal echo does have some limitations, especially in the prosthetic valve. Is this infection, or are these postoperative changes? Is that a vegetation really, or is it some sort of fibrous stand or thrombus? And again, it can suffer from artifacts and acoustic shadowing from devices and leads, and that can be tricky in the right hand side of the heart. CT is great. It can characterize the aortic root definitively. And you can acquire the status of the coronaries, which may be useful in the case of operation. The paravalvular anatomy is demonstrated amazingly, and it detects fistulas, abscess, and aneurysms. It's possibly less susceptible to metal artifact. And again, if you extend the field of view and if you scan the body and the brain, you can identify distant emboli. PET with FDG as the radio tracer is valuable in prosthetic and valve infection and device infection. It's got a reported low sensitivity in native valve infection, offers whole body imaging as we demonstrated, but the riders here is this post-operative expected inflammation, or is this truly infection? This is a systematic review of the use of diagnostic imaging in infective endocarditis published recently in the Lancet Infectious Disease. There are 3 CT papers, and there are many more FDG PET papers. However, the tenor of the review article is that these are all low quality studies, and the evidence is class C in nature. And that's largely because these are single center series with difficult to find gold standards. If I can share with you our own individual experience at the Barts Heart Centre, this is to look to see whether FDG PET had added benefit over the modified Duke criteria. We did a retrospective analysis of the patients that we saw through the endocarditis MDT. Saw around 400 patients, and 70 of which had PET scans. 30% of these patients were culture negative, and that's important because it's very difficult to actually get a diagnosis of definite endocarditis on the Duke criteria when you're culture negative. 40% of the patients ended up needing surgery. The prevalence of confirmed endocarditis was 68%, and we used a FDG PET dietary preparation involving a high-fat, low-carbohydrate diet, a 12-hour fast, and the IV heparin bolus to try and suppress physiological myocardial glucose activity, but that did fail in 3 out of those 70 cases. And we saw that there was an incremental benefit of PET over the modified Duke's criteria in both native valve and prosthetic valve endocarditis, with the areas under the curves increasing over the Duke criteria. But I think clinically useful is that if you look at the pie charts, the reclassification of patients from this possible bucket into either definite or rejected infective endocarditis was really quite powerful in both native valve and prosthetic valve patients. So after a PET scan, there's many fewer patients in that possible category, i.e. you have a diagnosis. Let me show you some more cases. 24-year-old, he has a tissue aortic valve, and that was performed for a severe aortic regurgitation in a bicuspid valve. He was fit and well, no other medical problems. But he first presents in February 2016 with fevers, rigors, and a sore throat. He was diagnosed with tonsillitis. The blood cultures grow Fusobacterium, and he receives 2 weeks of antibiotics. However, in April, he's back with high fevers, inflamed tonsils. He gets 10 days of antibiotics, but doesn't settle. His CRP is still raised, and he has this echo. I'm no expert on echo, but there's a space that is appearing around the prosthetic valve, and there may be some paravalvular leak around it. At that stage, he was referred to Barts and the infective endocarditis MDT. The thinking was that the current antibiotic regime that he was on would also cover the bugs for common causes of culture negative infective endocarditis. Right now, there are no indications for surgical intervention, but he was still didn't do well, and therefore he was transferred in, and he was teed up for redo surgery. CRP was still stuck, his fevers continued, and we performed an FDG PET scan. Again, whole body imaging starting in the pelvis. Here now into the abdomen. Into the chest. and the neck. So what that scan showed was ring uptake around the tissue aortic valve, but also tonsillar uptake and bilateral neck lymphadenopathy. On the basis of this, the decision was taken to perform a tonsillectomy, and with that you can see how his CRP fell. However, that was then complicated by pharyngeal abscess, needing another incision and drainage, but after that he was then discharged well and home. On follow-up, there's been no changes in the appearances of that valve on echo, and he's been fine with no further sepsis episodes. So the FDG PET scan here showed that there was an alternative source of infection, and when that was treated, the patient eventually recovered. Another case, 47-year-old man with a mitral valve repair some years before for rheumatic fever. He presents in October with a stroke, good recovery, but then in December he's being worked up as to why he had the stroke. There was no evidence of arrhythmia. There was mild mitral regurgitation and thickening of the valve leaflets on echo, and his inflammatory markers had been unimpressive, a CRP less than 5 and a white cell count of 7, and there were no systemic symptoms. Blood cultures showed 1 out of 6 gram-positive rods, and the question was this significant or a contaminant? Here is the echo of this repaired mitral valve. And an FDG PET scan was acquired. Just to take 2 images of that, just highlighting the uptake on the posterior element of that mitral valve repair. Nothing else, but then again, suspicious of active infection in endocarditis. So this is December. He was reviewed by the consultant cardiothoracic surgeons after that scan. No current evidence of infective endocarditis. They were thought, no indications of need for antibiotics. He should go home because it's Christmas, and we can keep an eye on him on echo over the holidays. However, he suffered a TIA on Christmas Eve, was transferred back into the hospital and underwent surgery, and that showed the angioplasty ring was infective and was eroding, and there was necrotic tissue, and he had to have a double valve replacement, and the valve grew strep sanguinis on cultures. So here the PET scan showed that there had been uptake in that valve, and that maybe if the images had been heeded, then he might have not necessarily needed that emergency surgery for the complication of a further stroke. So we can say that cross-sectional imaging is in the ESC guidance for infective endocarditis. However, it is based on low quality studies, and in part this reflects the difficulty of studying endocarditis. FDG PET has a role in prosthetic valve endocarditis certainly, and also can have a role in native valve endocarditis, or at least that's our local experience. But what is crucial is referral, discussion and feedback via the endocarditis MDT, because when everybody is there, surgeons, micro, the clinical cardiologists, echo doctors and radiologists, then we can synthesize all the information and hopefully improve outcomes. Thank you for listening. Please comment below if you have any questions. If you found that interesting, please like and subscribe for more lectures. If you'd like to know more, follow the BNCS on Twitter and visit our website. Thank you.